Hi there, my name is Reggie Casanova-Perez. I am a graduate research assistant at the University of Washington. Welcome to my talk called Broken Down by Bias, Healthcare Biases Experienced by BIPOC and LGBTQ patients. We have no relevant relationships with commercial interests to disclose. The learning objectives for today's presentations are: number 1, identify common pain points for BIPOC and LGBTQ patients who have experienced bias at healthcare. Number 2, describe patients' perspective on healthcare approaches for improving equitable patient-provider interaction. And number 3, recognize the need for clinical training and health system level changes to mitigate implicit bias in patient-provider interactions. We will start with some background. Implicit bias shapes healthcare providers' behavior and can result in health disparities based on race, ethnicity, gender, and/or sexual orientation. These biases, that may be subtle and unintentional, reflect prejudices and stereotypes that lead to well-recognized inequities in health and healthcare for patients who are Black, Indigenous, people of color, BIPOC, and lesbian, gay, bisexual, transgender, and gender diverse, LGBTQ+. As a result, Black patients are prescribed less medication, receive less aggressive heart attack treatment, receive fewer cardiovascular referrals, achieve poorer reproductive outcomes, report less patient-centered communication, and rate care quality worse than white patients. Meanwhile, LGBTQ patients report poor quality of care related to discrimination based on sexual orientation and/or gender identity, lack of provider knowledge and training about LGBTQ healthcare needs, a preference among heterosexual providers towards heterosexual patients, and insufficient research about the health of LGBTQ populations. Prior research has described the lived experience of BIPOC patients related to unfair treatment due to implicit bias. But to inform mitigating strategies that include informatic solutions, we need a deeper understanding of how marginalized and underserved patients experience unfair treatment related to perceived bias and discrimination. Which leads us to our objective. This was a qualitative study that investigated healthcare biases experienced by BIPOC and LGBTQ people and elicited their ideas for improving those experiences in future interactions with healthcare providers. We had two research questions for this study. The first one was, how do BIPOC and LGBTQ patients experience bias in healthcare? And the second one was, what solutions do BIPOC and LGBTQ patients suggest for improving those experiences in the future? For our methods, we had a 1-hour semi-structured remote interview with 25 participants. Our inclusion criteria for participant recruitment were to be BIPOC and/or LGBTQ+, to be 18 years of age or older, and reside in the United States. All participants received $30 after filling up a demographic survey and completing the interview. All the interviews had 2 interviewers and 1 interviewee, and were transcribed and redacted. Our participants had an age range between 19 and 60 years old and were racially diverse. We had 11 participants who were BIPOC, 3 who were LGBTQ+, and 10 who were both BIPOC and LGBTQ+. 1 participant did not report to be BIPOC or LGBTQ+, and described themselves as an older Asian woman. As for data analysis, we characterized and summarized qualitative data using thematic analysis, which included the development and refinement of a codebook. Now, our results. We found 8 themes related to patients' experience with bias. In this slide, we present a visual representation of how they interconnect. Our 8 themes, which are numbered, are distributed across 3 dimensions: the healthcare system, which is the purple rectangle, the appointment, which is the yellowish rectangle, and the patient-provider interaction, the green rectangle. In the healthcare system dimension, we found our first theme, system-level problems, which refers to when the patient feels that the healthcare system is unwelcoming and difficult to navigate. In the appointment dimension, we found our second theme, transactional care, which refers to when a provider treats an appointment as a job rather than an opportunity to look after the patient's well-being. In the patient-provider interaction, we found most of our themes. We start from left to right. Providers with implicit bias bring to the interaction with the patient our third theme, bias-embedded medicine, which refers to instances in which the patient felt that they were treated unfairly because of their personal characteristics, such as race, ethnicity, gender identity, sexual orientation, or physical characteristics like body weight. And our fourth theme, bigotry in disguise. That is when the participants perceive that providers had discriminatory attitudes or behaviors towards them due to being BIPOC and or LGBTQ+. During the interaction and between the provider and the patient, we found our fifth theme, power inequity, which refers to the power imbalance between patients and providers that affected rapport building. And our sixth theme, communication casualties, which refers to verbal or nonverbal cues that the patient identifies as uncomfortable, awkward, or inappropriate. After the patient realizes that they were treated unfairly, our seventh theme, fight or flight, captured the patient's responses to those situations, which ends up translated into our last theme, the aftermath. That are the consequences that biased experiences had in patients' lives. These consequences can include the patient leaving the healthcare system, which is why half of the theme is represented outside the healthcare system dimension. Now, I'm going to show you some representative quotes related to the patient's experience with bias. If you would like to see more quotes displaying our themes, please refer to the full paper. The first quote is from PT25, an LGBTQ plus patient who told us about a time where they went to the gynecologist and the provider joked about their girlfriend by using masculine pronouns when referring to her. This made the participant mad, and they reacted by shutting down rapport building and started giving very short answers without elaborating. This quote represents our themes of bigotry and disguise and fight or flight. The second quote is from PT15, a BIPOC and LGBTQ plus man who told us about a time where he went to get STD testing and the nurse lectured him for having what she qualified as irresponsible behavior. These quotes represent our communication casualty theme. The next quote is from PT11, a BIPOC and LGBTQ plus woman who had constantly complained about knee pain. One day, she got injured at a theme park and got x-rays done to her knee. There, she found out that she had arthritis and her kneecap was misaligned. Prior to that, she was dismissed by all the providers she went to because according to them, she only needed to lose weight and was never prescribed x-rays. This quote represents the aftermath theme. The last quote is from PT21, a BIPOC woman who stood up for herself after she was treated unfairly by a provider who dismissed her pain from an injury she got after performing as an artist. This quote represents our fight or flight theme. Regarding the solutions that BIPOC and LGBTQ plus patients suggested, we found two themes that relate to patients' suggestions for mitigating bias: solutions and good experiences. Solutions refer to the participants' ideas about what could help prevent the biased interaction from repeating. PTO2, a BIPOC woman, told us that she would like to have a robot that could intervene for her when the provider interrupts her. Finally, and as a surprise, participants organically compared their negative experiences with good experiences that they had with other providers. PT16, a BIPOC woman, told us about a time where she felt heard and cared by the provider who listened to her and accommodated her needs. The information gathered allowed us to understand the patient's experience with unfair treatment, which was our first research question. The challenges expressed by BIPOC and LGBTQ plus participants were consistent with prior research and gave us the opportunity to understand how they interrelate to each other. For BIPOC participants, we heard experiences related to racial and ethnic discrimination and pain misinterpretation. For LGBTQ plus participants, we heard experiences about poor quality of care due to discrimination based on sexual orientation and or gender identity, and lack of provider knowledge about LGBTQ plus healthcare needs. For both groups, experiences were about not feeling heard, being dismissed by the providers, and how impactful these biased experiences can be in the patient's physical and mental health, as well as to the patient-provider interaction. With this, we corroborated that institutional racism and homotransphobia remains a problem in healthcare. Additionally, we gathered the participants' ideas for designing informatic solutions. which was our second research question. Our findings can inform the design of healthcare services and technologies that make hidden bias visible, like having a friendly robot advocate, like the character Baymax from the Disney movie Big Hero 6, who could intervene when it detects implicit bias. The Good Experiences theme demonstrated that some healthcare providers may have already noted these interaction problems and contributed to enhancing the experience of patients from marginalized groups to the best of their abilities. As informaticians, we can leverage these findings to inform the development of technological innovations that improve the quality of patient-provider interaction by addressing implicit bias, even with simple and familiar technologies like electronic questionnaires to improve patient-provider interactions. This study had a number of limitations and strengths. One limitation being sampling bias. Due to COVID-19 restrictions, we were only able to recruit through virtual means, which skew our sample to be younger and college-educated, and potentially socioeconomically advantaged. Our sample was likely limited to the technological requirements for participating in the interview, which could have prevented people with non-technological backgrounds from participating. Another limitation is recall bias, which could have impacted the experiences the participants reported. Finally, we had a small number of participants who were LGBTQ+ and non-BIPOC, which limits the transferability of findings for this population. However, we captured perspective from 10 participants who were both BIPOC and LGBTQ+, which offers important insights of intersectional experiences. As for future work, we are doing co-design sessions with patients and providers for creating assessment tools that raise awareness of hidden bias in patient-provider communication. Additionally, we are examining experiences of intersectional individuals and how this intersectionality can be represented and incorporated into technological solutions. My colleague, Emily Bascom, extended on this last point in her presentation where she discussed the importance of considering intersectionality when designing patient-centered informatics solutions. If possible, I encourage you to see her presentation at session LB01. In conclusion, experiences of discrimination towards BIPOC and LGBTQ+ patients due to implicit bias can still be found nowadays in healthcare. Identifying and characterizing the lived experience and desired solutions help us to critically guide the design of informatic solutions to mitigate those biases, improve the quality of patient-provider interactions, and ultimately promote health equity. Thank you for coming to my presentation. My name is Reggie Casanova-Perez, and you can contact me with any questions or comments at reggiecp@uw.edu. Enjoy the rest of the conference.